Good day, dear friends. During these troubled times of COVID, lockdown, and difficult to manage times, I'm going to talk to you about a little bit of an issue with the COVID coagulopathy. What I shall be doing over the next 10 to 15 minutes is give you an overview of one of the important modalities of treatment in COVID. That is going to be the anticoagulation management in COVID. Now, what has happened over the years is last 1 year, a lot of things have changed. So simple, what I will do is take you through a few things. The first important problem was how much of VTE or venous thromboembolism and DVT do we see? Literature review showed something like 4.8 to 85%, which is like a huge difference. It's like talking like from 0 to 100, close to that. But when you look at a combination of all the data, what happened was that the VTE was about 17%, DVT 12, and pulmonary embolism in 7. And mind you, bleeding happened in about 8% of patients. But when you look at the ICU patients, it was there in about 29% and 7% only in the ward, clearly showing that VTE is more common in the ICU group of patients. Now, why does this happen so often in COVID? The simplest explanation given is there is a bidirectional relationship between inflammation and thrombosis. Three major mechanisms are proposed. We will not go too much into the theory. One is a dysregulated immune response. Two is an hypoxia-mediated induction of transcription factors. And third is a direct trigger like a thrombophilia or an endothelial dysfunction. So there are multiple mechanisms that have been proposed, and what has happened is the government has come up with a very beautiful staging of the disease. Most of it is accepted globally, but what we say is there is an asymptomatic patient, the mild, the moderate, and the severe. Now what we are going to be interested is in the mild, moderate, severe. Asymptomatic, nothing happens, they just become all right. The moderate and the severe are the two groups of patients who are going to be admitted to the hospital. Those are the two groups that are important. Who are these moderate patients? Patients who have a respiratory rate of 24 to 30, SpO2 of 90 to 94. Anything worse than this goes into the severe category. So these two patients are the ones we are interested in. Now, when you look at the guidelines from the government, this was published on the 24th of May, 2021, and we are interested only in the anticoagulation part. I'm not going to go into the full details of the whole thing, so only the anticoagulation. They got it spot on about one thing. There is no role for anticoagulation in asymptomatic and mild patients. But in moderate to severe patients, you need to anticoagulate. Now, this is what we're going to elaborate on right now. Now, we said all the moderate and severe patients are going to be hospitalized. And once hospitalized, how do we monitor for anticoagulation? That's important because when you want to monitor these patients for anticoagulation, we are going to be looking at platelet count, fibrinogen, prothrombin time, APTT. You are also going to be serially looking at Ddimer. Now the Ddimer is a very interesting part because the Ddimer levels change from normal to abnormal, or a rapid increase in Ddimer indicates that there is a progressive worsening of the infection. Now you need to treat them more aggressively. Now mind you, careful, because I said you have to aggressively treat. I didn't say aggressively anticoagulate. Mind that carefully. Now this is the guidance from the Tamil Nadu government, a scientific position statement. This was published in the 1st of January JAPI issue. I was privileged to be part of one of the members of this council, and what we felt, you go by the same mild, moderate, severe group, but the first thing you have to do is look at the bleeding risk of patient. First, do no harm, primum nocere. That's important because when you look at that, how to assess the bleeding score for coagulation as the Has-Bled score. Very simple score. Look at hypertension, abnormal renal or liver function, previous stroke, any bleeding history, labile INR if they are already on anticoagulation, elderly more than 65, and drugs, especially alcohol. Now there are also the ISTH scores which denote the presence of disseminated intervals of coagulation. Now here the platelet count, the fibrin degradation products, and the prolonged prothrombin time and fibrinogen levels come into picture. We just remember that there is a scoring like this, and there is also Padua score which is popular, which is used to find out if the patient requires anticoagulation or a DVT prophylaxis. Now these things are important scores that we have to be keeping in the back of my mind. But what is important is the Has-Bled score practically. The second point in this, what I want you to look at is this lower panel here. There are three kinds of anticoagulations we use. Normally, what we do is use the prophylactic dose and the therapeutic dose. The prophylactic dose, 40 milligrams of enoxaparin once a day, or it is going to be apixaban 2.5 twice a day, or a rivaroxaban 10 milligram. And the therapeutic dose goes to 1 milligram per kg of enoxaparin twice a day, or a 60 twice a day. Apixaban goes to double of 5 twice a day, and rivaroxaban 20 milligram once a day. But if you look at COVID, an intermediate dose has been proposed. Now there is some initial data on this which said that you either give 1 milligram per kg once a day, or give it 40 milligram twice a day, or give 5,000 units of heparin 3 times a day. Now, this is put the brakes on something. Now, what should we use in which group of patients? Now, interestingly, there was a very nice, interesting trial among patients admitted to the intensive care unit between the intermediate group and the standard dose enoxaparin. Now, our paper came up in January. After that, this beautiful paper came up and said there is no difference between standard dose and intermediate dose of enoxaparin. In fact, bleed can be slightly higher, but there is no significant benefit in ICU patients. Now, what has happened next is you remove the intermediate dose. We are not going to talk about that anymore. So what we are left with is the remaining patients. And among the remaining patients, the biggest data from Mount Sinai was the one that said, if you look at patients requiring mechanical ventilation, if you give a therapeutic anticoagulation, instead of no anticoagulation, mortality came down from 62 to 29%. This was the basis on which we started talking about anticoagulating these patients. Now that is something that we have to keep it in the back of the mind. And once a patient is admitted, someone who's got a serious infection is more likely to have a coagulopathy than mild infection. Logical, natural. And who is going to die from COVID? Those are the patients who have the ISTH criteria. Remember, I mentioned those criteria for DIC compared to the survivors. So the DIC happens more often in these patients who are going to die. What about elevated D-dimer levels? Rising D-dimer levels indicate that the mortality is higher and these patients have a severe infection. There could be impending cytokine storm, impending multi-organ failure, or a worsening of infection or sepsis. But it doesn't talk about anticoagulation. So what are the questions left at this point of time? One, in moderate COVID, wherein what is going to be the dose of anticoagulation, and can we use oral anticoagulation? Because these patients are not very sick. These patients are only in the wards, and do we use oral anticoagulation? The second question is, what about severe COVID? Do you use a therapeutic or a prophylactic anticoagulation? And what is the role of D-dimer, which we seem to be seeing more and more as a prognostic factor? Now, the government of India came up with a statement that clearly said that prophylactic doses should be used in moderate and prophylactic doses should be used in even the severe patients. Now, how sensible was that, looking at the Mount Sinai data? Now, actually, a couple of days after that, the ACTION trial was presented in the American College of Cardiology, which addressed exactly the same question. They looked at patients who were hospitalized and elevated D-dimer levels. Now, D-dimer, we said, is prognostic. They put one group of patients on standard of care prophylactic anticoagulation in the hospital and another group with therapeutic anticoagulation. The patient is sick, unstable angina, unstable patients. You give them a 1 milligram per kg twice a day of enoxaparin, or you give a stable patient with 20 milligram of oral rivaroxaban, all therapeutic doses. Once they are done with this, you can interchange between the patients depending on their severity of illness or sickness, how sick they are, and then subsequently follow rivaroxaban through 30 days. So this was compared, and what were these group of patients? In fact, when you look at the severity, most of the patients, nearly 82 to 83% of patients were actually in the moderate group, moderate severity group. So then what happens? You look at the efficacy outcome. There is a clear reduction in thromboembolic events, but the all-cause mortality was higher, 1.49, significant increase in mortality. What about the safety of these patients? All parameters of bleeding obviously were higher in the therapeutic range. So what is the final conclusion? So in a patient with COVID-19 and elevated D-dimer levels, on therapeutic anticoagulation, it did not improve the clinical outcome. In fact, there was an increased bleeding. So when the D-dimer levels were elevated, this is what we found. So what are the learning points from this? One important point is the D-dimer is actually a marker of the severity of infection. It is not a marker for increasing the dose of anticoagulation. There is also a direct inhibitory effect on fibrinogen by the D-dimers, and serial elevation is very unreliable because you cannot rely on this, because there can be something like a consumption coagulopathy wherein the patients can bleed, and elevated D-dimers are going to be there even in a consumption coagulopathy. So the fibrin degradation products are going to be there, and these patients, if you start giving heparin or if you start giving an anticoagulation, they will bleed. That is possibly the reason why an elevation of D-dimer may not be a reliable marker. So you have to go for the other scores like the ISTH scores. So anybody who's in the ICU sick, I think you have to be monitoring these patients much more carefully. The second interesting data that I wanted to share with you is going to be on the multi-platform trial. This is 3 studies, REMAC-CAP, ACTIV-4 and ATTACK. Together, they studied 2 groups of patients. One is those patients with the ICU level of care. Now you have to listen to this a little carefully, because those requiring high flow nasal oxygen, invasive or non-invasive mechanical ventilation, vasopressor therapy, or ECMO support, these are classified as ICU level of care. Now these patients were grouped into one group, and the other patients who are in the hospital are called moderately ill patients. Now first we look at the severe patients requiring ICU level of care. Clearly, Mortality, not much of benefit. There's mild benefit, 35% to 3.2%. Slight reduction in thrombotic events, but a significant increase in the bleeding. What about the moderate state? Need for organ support significantly came down from 23% to 16% when you started using therapeutic dose of anticoagulation. So instead of the prophylactic dose, if you use a therapeutic dose, it is not beneficial in severe patients, but in patients with moderate disease, it seems to be beneficial. Mortality came down from 7.7 to 5.7. Thrombotic events came down. Major bleed, it showed a marginal increase, but I think the benefit seems to be significant among moderate severity patients. So where do we stand at this point of time in terms of anticoagulation? One thing we have to remember is these mild patients who are already receiving an anticoagulation or on antiplatelet therapy for underlying conditions, you must continue. Please don't stop. That's very, very important. Remember this. If you're already on anticoagulation, you have to continue. What about the severe patients? Prophylactic dose seems to be the better option. ICU level of care. This is the group of patients with severe infections requiring high flow nasal oxygen, invasive or non-invasive mechanical ventilation, vasopressor therapy, or ECMO support. The probable moderate group, the data or that I said, the three trials are not yet published. So we will keep it in the gray area, probably requiring a therapeutic dose of anticoagulation. Now, a few practical problems I thought you should be aware of. As the disease progresses, the platelet count starts coming down and the fibrinogen levels keep changing and sometimes it keeps decreasing. Now we are anticoagulating these patients. Now the important question is, till what level can you continue the anticoagulation? When not to keep the anticoagulation? If it is going to be a therapeutic dose, platelet count up to 30 to 50,000, you can continue the therapeutic dose. Fibrinogen up to 1 gram. If it is going to be a prophylactic dose, even 20,000, you can start giving prophylactic dose, and the fibrinogen till it is less than 0.5 grams, you can give the anticoagulation. Now these are practical tips that are going to be there. Now there is going to be a patient who is already on warfarin, patient with prosthetic valve develops COVID and comes to you. What we find is that nearly 70% of patients have a sub-therapeutic INR at admission. What's the importance? They're not getting adequately anticoagulated. And then if you start treating those patients with antiviral therapies, there is a cross interaction with warfarin. So what is the recommendation? Very clearly, if you're going to be an antiviral therapy, maybe you should consider bridging with anticoagulation at that point. There's no clear guidance. Maybe you consider if you're going to give antiviral therapy. But all the other patients have a gross fluctuation, like I said, 70% subtherapeutic. They could end up with a valve thrombosis. Because of that, you have a more frequent monitoring of INR if they get COVID. Every 3 to 6 days, you monitor the INR and make sure that they are maintaining a therapeutic range, or you're going to have a thrombosis of these valves of these patients. So that is important. But what about a pulmonary embolism? Somebody develops a pulmonary embolism, you diagnose by simpler measures, RB dysfunction, TROP, or BNP elevation or hypotension. If you have confirmed COVID in these patients, what do? Those patients who do not have a hemodynamic compromise, you follow up with a full therapeutic dose of anticoagulation. But if you have a high incidence of decompensation like hypotension and those patients requiring anticoagulation, it is very important to note, because of the increased incidence of bleed, you consider giving half dose anticoagulation first, look at response. If they respond, good. If you don't respond, then you can go for a second dose of complete anticoagulation. That is going to be half, and then you repeat the second half. Now the interesting portion is it's become a big interesting fanfare in India. When patients get discharged, everybody celebrates. Now what about the DP and thrombosis post-discharge? The actual incidence on day 42, it's very, very low, only 2.6%. So how do you identify this 2.6% who are going to develop deep vein thrombosis? Now there are simple criteria. To improve VTE score of more than 4, or improve VTE along with the Ddimer value elevation. Age more than 75, 60% increased Ddimer, or between 40 and 60, you probably have both and a previous history of VTE. Now, what is this improved VTE score? Simple score. You look at previous thrombosis, patients with thrombophilia, current lower limb paresis, history of cancer, ICU stay, immobilization, or age more than 60. Now, what is important is, instead of remembering all these things, anybody who's got an ICU stay and somebody who's immobile, you send a patient, most of the patients are not mobile when they go home following COVID. You look at the immobility score or the mobility score, the Parker score and the Parker and Palmer score shows a simple patient who's not mobile as 0. If you are going to do with help from 1%, 1, with a walking aid 2, without difficulty 3. You look at three parameters: indoor walking, outdoor walking, probably able to manage your shopping. So the score of 9, as the number increases, the chances of you getting a deep vein thrombosis at home is going to be much less. So this is also valid So look at both the above factors and mobility scores. Take a note of that and remember anticoagulation. A lot of people rely on D-dimer. Now this is a very interesting point that I want you to understand. There is a simple study which said even 6 weeks following discharge, there can be a sustained elevation of D-dimer in 25% of patients. And these patients did not actually, some of these patients underwent a pulmonary angiogram and they found out that they did not have pulmonary embolism. So D-dimer may not be a reliable marker subsequently following discharge for you. So don't rely on that for continuing your anticoagulation. So to summarize, who is going to require an anticoagulation following discharge? We said that patients who are going to have these risk factors are going to benefit. How long? Minimum of 14 days, and depending on the patient and how you reassess the patient, and then you can go up to 45 days of anticoagulation. But if you have a documented VTE, 3 months of anticoagulation minimum. Depending on the scenario, you have to go ahead. But whenever you want to use a prophylactic anticoagulation, mind you, the VTE patients get a therapeutic dose of anticoagulation. Prophylactic anticoagulation, there are several drugs. The low molecular weight heparin for 14 days can be recommended, but the US FDA approved medication is 10 milligram of rivaroxaban. Betrixaban is not available. Apixaban twice a day, 2.5 may be used, but the recommended dose is going to be 10 milligram once a day of rivaroxaban. Now, why is it that we don't use the NOACs in ICU? Simple, longer half-life. If you want to stop it and do a procedure, it's going to be difficult to reverse them. Antivirals have an interaction with them because they increase the NOAC levels, and several other drugs, including the steroids, the anti-epileptics, phenytoin, carbamazepine, phenobarbital, all these can reduce the levels of DOACs. So there's a lot of drug interactions. So in ICU patients, sicker patients, possibly not sensible to use NOACs. And several drug interactions have been known. The safer green area is the ones with low molecular weight heparin, unfractionated heparin, and the fondaparinux. So in hospital, that is going to be drugs. So when do you use the NOACs in hospital? Possibly when you suspect heparin-induced thrombocytopenia. If you use fondaparinux, good, but fondaparinux is not freely available, you can probably start using a NOAC in that place. Any data on NOACs? Safety of NOACs, especially the rivaroxaban, has been found in mild pneumonia and severe pneumonia. There has been some safety data with apixaban also even in ICU patients. And there has been some say, but now that we're talking about prophylactic dose and all these interactions, may not be sensible to do it. What do we look forward to in the future? There are a lot of trials coming up. There are outpatient trials, significant, important outpatient trials on patients who have not been hospitalized. They're trying to give a small dose of rivaroxaban and apixaban. 2 important trials are in the pipeline. ICU patients with fibrinolytic therapy and aspirin are also in the pipeline. Post-discharge also, DOACs in 2 trials is in the pipeline. So we might have a change in the scenario in the next couple of months. But at this point of time, what is going to be the model that I'm going to give you? Clearly, COVID is a prothrombotic state. D-dimer is a marker of severity. It is not a marker of increasing the anticoagulation. NOACs may be ideal, may be used in heparin-induced thrombocytopenia or extended thromboprophylaxis. And rivaroxaban is the one that is recommended and approved for thromboprophylaxis. You probably have to look at the improved VTE and the mobility score to anticoagulate patients at discharge. The last summary is this one. Mild patients, you have to continue anticoagulation or antiplatelet depending on the underlying conditions. Please don't stop. Patients with moderate disease, at this point, it might be stable or sensible to look at patients who are on low risk for bleed, go in with a therapeutic dose of anticoagulation. Patients with a severe or a critical disease, look at prophylactic dose. And who are those going to be patients? Patients requiring high flow nasal oxygen, invasive or non-invasive mechanical ventilation, vasopressor therapy, or ECMO support. So these are the patients who are going to be there. Always mind you, do no harm. Look at the bleed score, HAS-blood score, and see that your patient is safe. I think I have managed to give you some information about it, made you think about this particular problem, and thank you so much for listening, and thanks for the opportunity for given to me. Thank you so much.